Thank you all for coming. For those who I don't know, I'm Sandro Galea. I have the privilege of serving as the Dean of the School of Public Health here. And this is part of our monthly Public Health Forum series, where we invite leading scholars from around the world to address issues that we think are critical to public health. And we have one such scholar today. We're absolutely delighted to have with us Professor Ellen Wright Clayton. So very briefly about Professor Clayton, because otherwise I could stand here the whole time. She is a leader in the field of law and genetics, and she is at Vanderbilt University, where she's in both law and the medical school. She co-founded and directed the Center for Biomedical Ethics and Society for a long time. She has she has an extraordinary publication track record, which I actually won't go into. She also has been a national leader at the National Institutes of Health, at the National Academy of Medicine, where she serves on the Executive Committee of the National Advisory Council, and she chairs the Board on Population Health and Public Health Practice. She's chaired a number of committees, and she's also an elected member of the National Academy of Medicine, obviously, and the American Academy for the Advancement of Science. And most importantly, Professor Wright Clayton has written some of really the most interesting and seminal work around the intersection of ethics and genomics and how that influences the world in which we live today. So I am truly excited to have her here and to listen to her talk. Ellen.
Well, it is a great pleasure to be here and to talk with you about a couple of issues that I think are really timely at the moment. Before I do that, I do, however, want to say that it's also really fun to come here because I've known many of the faculty here for probably more years than they want me to tell you, and it's really fun to get to see them again and catch up and think about all the ways that they have actually influenced me in the past. In my own work. So I'm going to actually talk about two things today. One of them is why precision medicine needs public health, and then I'm also going to say why public health needs to worry about the notice of proposed rulemaking about changes to the common rule that affect research regulations. I'm going to make two sets of disclosures. Here's the first set. I have no ownership conflicts of interest. I don't own any interest in any healthcare companies that I know of. I will confess that I've gotten an honorarium or two for talking about genetics, but that's really the extent of it. I have been thinking about genetics and genomics and its appropriate use in research and clinical care for decades. I wrote my first article appeared in 1978. So this has been a long-term concern of mine, and it's one with which I am still actively involved today. And as you've already heard, I chair the Board on Population Health and Public Health Practice at the Institute of Medicine, which is what the program arm is currently called. So I have been sort of straddling this space for quite some time. I want to begin by talking about the Precision Medicine Initiative Cohort program, which was announced earlier this year by President Obama, and then a group of people were gathered together over an extended period of time and issued a report on September 17th of this year talking about this particular study having to do with precision medicine. Here are some elements of this particular project. They are going to plan to recruit 1 million people to be in this study. A combination of direct volunteers and targeted recruitment, and they are going to get baseline physical examinations, seek access to electronic health records where that's possible, obtain biospecimens, and have people agree to be recontacted. There are some issues about how representative a sample like this is going to be. But nonetheless, that is a major feature of this. They also, I think very interestingly, talk about participant engagement and research oversight. This is I think, a laudable trend in many ways because it's pretty clear that underrepresented minorities are not going to be in these studies unless they are engaged more fully in what's going on in the research process. The details of what this is going to look like have not yet been spelled out, and there are some concerns about whether some of the things that they propose are actually possible. without legislative change. They propose that there be a standard consent form with an option for what information is the individuals are to receive and for further participation. I'm going to talk a little bit more. They don't really talk in this particular document about exactly what the consent form is going to look like, but I think we have a premonition of this when we look at the notice of proposed rulemaking, which I'm going to spend a fair amount of time talking about. The idea, it's interesting also that they allow people to have choice about what information they receive from participating in the research, because frankly, there are a number of protocols currently going on in this country that now require people to get research results from research participation. So this is an important issue. They also talk about centralized data collection and oversight. This will clearly be critically important for this particular study in order to make sure that there's some uniformity. Exactly how that's going to be made to happen, I think, is unclear. They also interestingly say that participants are generally to have access to their own data. This is not surprising, I think, given the particular debate now in which so many people are saying that they want to have access to their research results. And when we see the HITECH Act, which now is saying that patients, as a matter of right, have access to results that are available in their electronic medical record. They also suggest that participants are going to be involved in deciding what results are to be returned. This is one of the most vexed issues in genomics research today. I say that deliberately because we are now able to do sequencing, a variety of other multiplex technologies, and there are major, major debates about how you decide what results are to be returned, what results actually are correlated with causing disease, how you're going to do it, where it's going to go, and what kinds of actions follow upon it. Every research consortium that I currently am involved in, and I'm involved in two, one is the CSER consortium, which is clinical sequencing exploratory research. The other is the eMERGE project, which is electronic medical records and genomics. Every single meeting focuses on how on earth can we figure out what variants cause disease, how likely it is that they can cause disease, what criteria are you going to use to decide what to return, how are you going to do it. Patients are saying, or research participants are saying, we're entitled to everything. This is one of the most vexed issues in research today. Importantly, I think this study actually also pays attention to some policy concerns. One of the major issues that we confront in genomics research today is that people are worried to some extent about how genetic information is going to be used about them. Are they possibly going to be harmed? We have spent very little effort trying to talk about how to penalize misuse. And one of, I think, the most innovative things that this committee recommended was to say that Congress should pass laws that actually penalize people who misuse genomic information. My criticism of that is that it ought to be not only for the Precision Medicine Initiative, but also for all other kinds of genomic information. Now, I say that recognizing in my own research, which also looks at the actual risk that someone is going to try to re-identify genomic information, and which reveals that it is very rare for someone to try to re-identify genomic information, that clinical information or phenotypic information is much more identifiable, it is much more likely to get lost, it is much more likely to be accessed and used for inappropriate uses. So we have a lot of data about this. The concern about genetic re-identification is completely misplaced, but nonetheless, it's a major issue out there. And the way we need to deal with this is to say that there need to be penalties for people who misuse all kinds of research information, not just genomics. I do have some criticisms about the Precision Medicine Initiative and what they plan to do about social factors. And they do have some plans about how to think about social factors that affect health and disease and how it may come into play in thinking about the role of genomics in coming up with precision medicine. First of all, they are very interested in the possibility of using smartphones and Fitbits and other mechanisms like that to try to figure out what people do. And indeed, there were 4 public data sessions before this process rolled out, and the 4th one was about how we can use all these fancy gee whiz gizmos to track what people are doing. Tracking not only do they walk, do they run, what's their blood glucose, what's their blood pressure, many things like that. They also talk about using GPS to measure environmental pollutants, looking at historical data, to look at weather, to look at air quality, to look at activity data. They also talk about self-reports by participants in this project, particularly around things like diet, one-day diet recalls, things of that nature, some things about surveys, and some things about social network data. Now, all of these, particularly the last 3 of these, are actually really pretty ill-defined. And they pick up on themes that we're, pretty interested in. I mean, there's a lot of evidence that suggests that who people hang out with has an impact on whether they're obese, whether they smoke, whether they do engage in a number of activities that may be bad for your health. But I want to argue that this list is way too narrow and that there is a major, major opportunity being missed here. And this is a role for public health in this. So these things that they will assess are environmental pollutants, whether you eat bad food, who you connect with, many other things of that nature. But we have much more complex notions about, about factors that increase health, that affect health across the lifespan. This is a diagram from the Annals of the New York Academy of Sciences, one of whose authors is Nancy Adler. And I don't intend actually for you to read this, although I think it's really pretty helpful, except to say that we are much more than our genome. We are much more than whether we run or walk, what we eat, who we hang out with. That it's actually much more complicated than that. And we actually know that, and we've known that for a very long time. So before I came here, I had a chance to read a really terrific article by Ron Bayer and Dean Galea that appeared in New England Journal earlier this year, who made the point that every single person in this room knows, which is if you want to look at what affects health outcomes, it's actually poverty and education. We know that being poor affects your health, leads to premature mortality, that low education affects your health, leads to premature mortality, and that there are aspects of our society like institutional racism, institutional sexism, that adversely affect our health. We have lots and lots of evidence to show this. And yet, we don't see these factors reflected in the Precision Medicine Initiative. Now, maybe that's because it's not all that sexy, or it seems too intractable. And so the first thing that we ought to do before we even get around to talking about what the Precision Medicine Initiative is going to do about this is to do what we know we need to do. That what we need to do is that we need to address these inequities in their own right. That is a primary moral and political mandate. And it needs to go on regardless of the Public Medicine Initiative. So I want to emphasize that point first. We know this, you know this, it is what we have to do. It's what some of the students I had lunch with today told me. These are things that are absolutely essential to address in our country. But we also need to think about how to get them involved in the Precision Medicine Initiative. So I'm going to suggest to you how we do that, or how you do that. And the hook is epigenetics. For those of you, this is like neo-Lamarckism. It's really funny to see all this coming back around. But we know, I mean, when I was your age, I was taught that the genome stayed the same your whole life. And that nothing happened to it. And we now know that, of course, that isn't true. We know that our telomeres get short. We know that there are things that get attached to our genomes, methyl groups, other groups that get attached to our DNA that affect what genes are turned on and turned off. We know that that process begins during pregnancy, prior to delivery. We know that it occurs as a result of, and it occurs across the whole life course. We know that it occurs as a result of child abuse and neglect. We know that all of that happens. And that there was a study or a report issued by an AAP committee on the lifelong effects of childhood adversity and toxic stress. And they said that there is a strong scientific consensus that the ecological context modulates the expression of one's genotype. Similarly, an NHLBI working group on epigenetics and hypertension asked the following questions. Are epigenetic changes causal? Do they make us have differential health outcomes? Are they heritable? Believe it or not, some of them are. So that something that happens to me early in my childhood actually may affect the health of my children, which is pretty frightening. Do they accumulate across generations? Can they be reversed? Now, the reason I think this is the hook for public health is that we can make the case, you can make the case, that without looking at toxic stress, without looking at the impact of poverty, at the impact of low education, that we, in fact, are not going to come to a complete understanding about how those incredibly important health outcomes or those health stressors actually adversely affect health outcomes. We'll be able to see the epigenetic changes for sure because we know how to look for them, but we won't know why they happened because we didn't ask the question. And so what I want to argue for you is that the challenge is to figure out robust ways to measure poverty, robust ways to measure education and stress to inform the research on precision medicine. Because unless we collect that information, and it's going to require more than just geocoding, it's going to require looking at actual income, it's going to require looking at some of the things that stress families, broken families, child abuse, family splitting up. Unless we collect all that data, we won't know. Now, that's not to say, here's the right solution to those stressors. Fix the stressors. That's the right solution. But what I can tell you is that unless we measure those stressors, we will not get the right answers. And we will not know how to do precision medicine. Now, I want to be clear here. I don't think that precision medicine is the answer to all of health problems. This is for someone who's been thinking about genetics now, almost without stop for almost 40 years. That's kind of hard to say. But I will say that we will come up with answers that are wrong, and that will lead us in the wrong direction. So I would urge the leaders in this room to get included in the table, to get included at the table, to say, we must figure out how to ask these questions, how to gather this data, and how to incorporate it going forward. It will be difficult. It will also be ethically complicated, because sometimes we're going to come up with answers that we don't like. But I think it's absolutely, absolutely essential. And I think that with the failure of public health to get at the table will be a terrible outcome. Now, disclosure 2 is that I am a strong component of the collection and use of biospecimens and data for research. And I have been deeply involved in the creation and evolution of BioView, Vanderbilt's DNA data bank from leftover blood samples, and in research using that resource. Until recently, that resource was an opt-out resource, which caused a lot of controversy. It is now an opt-in resource, not because, and the reason for that is because of the genome data sharing policy, in which the NIH basically said that in order to get funding for research, we had to give people the choice about make them exercise a choice about whether they were going to be engaged in this research or not. I have to say we did a lot of research when it was opt-out. We found that most of the people at Vanderbilt really liked it. And their views about it haven't really changed since we moved to opt-out. So I have a lot of experience thinking about biobanking, thinking about what it takes, thinking about what people think or don't think. And I will just mention at this point that we have just finished, a bunch of collaborators in the eMERGE Consortium have just finished a systematic literature review looking at the public's views about broad consent and data sharing, which I'll be happy to talk about if we want. We've also just completed a survey of 12,000 people with deliberate oversampling of underrepresented minorities, looking at views about broad consent and data sharing, trust and views about trust and privacy. We are in the process of exploring that data now. So this has been something that I've been involved with for a long time. I make this disclosure because now I want to talk about what happened in the Notice of Proposed Rulemaking and why it is catastrophic not only for research, but also for public health. So, I want to begin by saying why, and let me say a little bit about the Notice of Proposed Rulemaking. A number of years ago, well, in 2010, the Office of Research on the Office of Protection of Research Participants issued what was called an Advanced Notice of Proposed Rulemaking, in which they proposed a number of changes in the rules that govern research with human research participants. And so these actually sat around for quite a while. They elicited a lot of comment. They proposed among other things, that all biospecimens were identifiable per se, and a number of other issues. That went on until this year when actually and recently they issued the next step, a notice of proposed rulemaking. This was driven in part by the fact that Congress passed a law called the Newborn Screening Saves Lives Amendments of 2014, which demanded that this be issued by the middle of July. They missed it. But that the final regulation be issued in December of next year. So that's what the deal is. And so they have made a number of sweeping changes in what we now, and the way we deal with research regulation. But the one that I really want to focus on is biospecimens. And I'll just give you a heads up to say that what they have done will actually be extremely problematic. So why should public health care about this? After all, you have an exclusion, or a limited exclusion, for public health surveillance. And the language of the regulation, always the first place to look for those of us who are lawyers, is limited to those that they can use biospecimens so long as they are collected or authorized by a public health authority, and limited to those necessary to allow the public health authority to identify, monitor, assess, or investigate public health signals or the onset of a disease, or something that's happening in the case of man-made or natural or man-made disasters. So what does that mean? What it means, if you go back and look at their language, is they mean this to be a very, very narrow exception. They mean this to be, if you've got a major infectious disease outbreak, if you have a major earthquake, if you have some major toxicological event, then public health authorities can collect biospecimens without consent. They may even be able to do secondary research on some of those samples without consent. But they are explicitly forbidden to do any exploratory research without consent. So things that are looking at the connections between biomarkers and health outcomes, between diet and health outcomes, any exploratory research is excluded from this. Now, hold that in your mind, because it means that public health authorities and who they designate have this limited exception. They then describe a public health authority as, a number of entities that they talk about here. So why should public health care about the NPRM? Within the constraints that I talked about, then the public health agencies don't have to, are not subject to these rules, but everyone else is. So let's talk about what the new rules are, and then I'll talk with you about why this matters a lot for research and for public health surveillance in general. I want to go back and say one other thing about surveillance. They do not mean general public health surveillance is exempt from this rule. They mean very special circumstances. So this is a really important distinction. So the summary of the Notice of Proposed Rulemaking is that biospecimens are treated differently from everything else, including identifiable private information. So under the HIPAA rules, identifiable private information is treated very specially. Biospecimens are treated they're even more special than identifiable private information. Identifiable private information would be information about me that has my name on it, that has my address, my phone number, my social security number. That's IHI. biospecimens, whether they are identifiable or not, are treated even more restrictively. They require a written, multifaceted consent. You cannot waive written consent, except in extremely rare circumstances, for cultural reasons. For almost all the time for the collection and use of biospecimens, they say that the form is to be short and comprehensible. They say that a model form is going to be developed, that if you use it will mean that you've complied with the regulations. They are concerned that biospecimens may soon be easily identifiable. The language they use is they say, it is acknowledged, that's their word, that biospecimens are going to be identifiable in the near future. I think that there is real reason to be concerned about whether that's actually true or not, or whether people would try to do them if there are other ways to get the information. However, once you get this written consent form, there's no IRB oversight. And all that's required is reasonable and appropriate safeguards for biospecimens. They're going to develop some model safeguards that will be reviewed periodically, but in the absence of those, HIPAA security will do. So let's see what the consent form looks like. That's it. Okay? So I mean for you not to be able to read this, but I want to be clear about what this says. So what this says is that the stuff that's in black up at the top, up to option to refuse, allow investigators to recontact. It allows them, these are drawn from the general requirements of informed consent forms for IRBs. Risk to subjects, benefits, extent of protection of confidentiality, whom to contact, whether statement that a specimen may be used for research, for commercial use, and that whether someone may share in the profit, that's never going to happen. Whether individual results will be returned to the subject. This is important because if you are going to give individual results back, then you have to have full IRB review. What that means is that as much pressure as there is to return results, there will be a huge incentive not to do so, because then you get full IRB review, and whether you can, whether investigators can recontact you. The blue stuff, if you can see the color difference there, are new explicit disclosures that are required for every collection of biospecimens. So this is all brand new stuff. And let's go through this. How they're going to be used for research, a clear description of how they are going to be collected, where they're going to be collected, how long they're going to be used. There's a 10-year sunset rule, which I can talk about because it's sort of odd, that you can withdraw if you can, and the names of where the specimens and identifiable private information are going to be done. The stuff in red applies only if it's applicable. So if they're not going to be informed about specific research subjects, they need to be told. The next one actually permits, as a matter of regulation, that people can give broad consent for data sharing without limit. This has been an issue that's been discussed a lot in research ethics. This makes it explicit. You can do it. Now, I want to be clear here. It is not required. So it's possible for an investigator to do more narrow consent, but I'll give you a little example of something that will make this even more challenging. And then that adults can actually agree to open access to data, like putting it out there on the web, like James Watson or Craig Venter or the Personal Genome Project or other things like that. I look at this list and I say, how can this be short and comprehensible? I don't get it. And I've been in meetings where people will say, well, the Secretary of Health and Human Services can come up with a shorter list. Well, you know, this is the regulatory requirement. So the Secretary of Health and Human Services can't come up with a shorter list because this is the list. You have to have all of this. So that's what the consent form looks like. So there are some times when you can actually, these requirements can be changed, either public benefit or service programs, or previous rules for a waiver, plus you can't do the research any other way. Okay? And, or the other requirement, which I think makes a lot of sense, is if someone's previously agreed not to give broad consent, you can't fail to ask them again. You can't waive consent and say, well, you wouldn't do this in the past, but we'll just do it anyway. That's not okay. That seems pretty clear to me. The take-home message here is super clear. Written consent or written signing of the document with extensive disclosure is almost always required. This is a lot of information. So here are some questions that I want to ask about this disclosure. First of all, will it help people make informed choices? We know for sure, we have lots of data, that disclosures like this are not read and they're not understood. How many of you have read a EULA, End Use License Agreement, when you click through a computer program? None. How many of you have read the HIPAA privacy form when you go to your doctor? I mean, this is worse than that. I mean, no one is going to do this. And particularly people who don't know much about the research enterprise are not possibly going to be able to read this and understand it. What is likely to happen is that it's going to be routinized, just like the HIPAA privacy form. And here's a big game changer. A big game changer is that this will have to be in surgical consent forms if you might want to use surgical tissue for research. It will have to be in consent to treat forms when you enter the clinic. Because I don't know if you're like me, but every time I go to the doctor, you know, they withdraw my entire blood volume. And I do happen to know, I mean, I happen to think it's going into BioView. I don't know because we actually exclude some people. But the fact of the matter is that this is going to have to be part, if we're actually going to use these specimens for research, in every consent form, all of this stuff. So what is that going to mean for an academic medical center? We know how to do this at Vanderbilt. I mean, with BioView, we actually have a way to do all of this, and I guess we'll do it if we have to. But think about the hospitals that aren't, academic medical centers, that are, in communities. No chance they're going to be able to do this. No chance they're going to choose to do this. And so the result is going to be that the number of samples that can be used for research is going to be much less. Why does this matter for public health? Well, because if the samples aren't collected with consent in a local hospital, then how are you going to use them if there's something you want to monitor there? Not something that's an outbreak, not something that's a catastrophe, but is that something as a public health surveillance issue you want to look at. But you can't look at the biospecimens. So that's a major change. The other thing I find extraordinary about this is that their argument for doing this way is that it will honor autonomy. Now, I don't get how you honor autonomy by creating an ultra-complex form that, that people won't read and can't understand. I don't get it. But they also argue that this is really going to enhance the recruitment of underrepresented minorities because it's going to increase trust and increase participation. Now, I've spent a fair amount of time thinking about how you include underrepresented minorities and other vulnerable groups in research. And giving them a long, complex form is not the way to do it. The way to do it is by engagement, by building trust, by giving them oversight, by doing something other than this. So I find this to be a really extraordinary development. And so I've already made this point that for this to be implemented, these consent requirements will need to be implemented in every surgical consent, every consent to treat. And then I think you have to ask the question, should written consent be required for virtually all collections of use of biospecimens? Now, for decades, this has not been the case. For decades, there have been responsible uses of biospecimens that are de-identified for research without issue. And we've actually done, or not we, but actually many studies have asked people what they think about this. And a lot of people think this is fine. So this concern that we have to have written consent for all uses of biospecimens is true for some people. It's not true for all people. And so thinking about this, we have to ask the question, is this really the right decision? Now, I'm going to go to another topic that makes this point even clearer, I hope, about biospecimen exceptionalism. These next 3 slides are from the slides that Jerry Menikoff, the head of OHRP, uses and to talk about this. And this is talking about how proposals affect secondary research with data. So research, not what was contemplated initially, but what someone's interested in using later. The general rules for that haven't changed. De-identified data that already exists can be used. In fact, they expanded to talk about data that are extended into the future. Here's the real big one for me. And by the way, I haven't highlighted anything on these slides because I didn't change these slides. These are their slides, so no tinkering. Furthermore, new rules relating to biospecimens do not alter rules related to secondary research with data, regardless of whether data had been obtained from a biospecimen or some other way. So what does that mean? It means that you have to have consent to use the biospecimen in the first instance. To do your sequencing, to do your toxicologic studies, to do your pathologic studies, whatever they are. But once they have data, it's different. And I'll show you how. All data, regardless of source, are treated the same way. So hold in your mind, you've gotten a biospecimen, you've gotten consent. It wasn't broad consent, just consent. You do whole genome sequencing, okay? Hold that in your mind. What this change in the rules does is it says that it increases the ability to use identified data for research without consent. And that new broad consent forms can be used to get consent, but they're not the only way. And that, in fact, once it's data, then there are many other options for the researcher other than obtaining broad consent. So researchers could use data stripped of identifiers. That's what we do currently. Keep a one-way link to identifiers. Some people do that. Allow IRB waiver. Or they even have a new one that says that investigators can say we're going to tell you that we're using identifiable data, and just so you know. okay? So think about this. So you have your biospecimen, you've gotten your whole genome sequencing. You can strip it of identifiers. You can keep a one-way link to identifiers. Jerry said that you could use de-identified DNA in the same document that is arguing that DNA is not de-identifiable. So, but many other things. So the question that I want to ask you here is it appropriate to treat biospecimens differently from everything else, including the data from biospecimens? They say that the reason that they are asking about biospecimens is because people want to be asked about biospecimens. Well, they want to be asked about data too. People are worried about data from biospecimens. Not everybody, but some of them are. And in fact, if you think about it, the number of people who are concerned about how a particular tissue sample is used, the biospecimen itself, is probably a whole lot smaller than the people who are concerned about the data. And yet the data are actually more widely available without consent under this new rule than the specimens are. So, to finish this up, I would say that, first of all, just to reiterate, public health needs to be at the table about the precision medicine initiative. Public health also needs to say and continue to say that the precision medicine initiative is not going to solve health problems, that the answer to health problems is also going to include doing the kinds of things to make a more just, more fair society, to be sure that includes better access to health care, but more importantly, contains better access to education, better access to income, that allows people to thrive generally. That's what improves health, and we know that. And the thing that we need to be saying about the NPRM is that the treatment of biospecimens is, first of all, going to have a devastating effect on research, because lots of people aren't going to sign these forms. And that frankly, their very narrow discussion about what is contained within public health surveillance is not broad enough to do all the things that public health ought to be doing. And that it's a real problem that they are making data, even data from biospecimens, more widely available at the same time that they say that biospecimens themselves are too risky or are too difficult to do without consent. I think we really have to address this. I think it's important for public health to go. The due date for the comments, by the way, is December 7th. I don't know if it's going to make any difference or not, but that's when it is. Now more than ever, public health needs to be speaking truth to what we're doing in this crazy world of biospecimens and precision medicine. Thank you very much. Any questions or comments? George? How did I know?
Ellen, thank you. I thought that was brilliant. I don't use that word. I love that you put together the precision medicine and the new proposed regulations, which I think is exactly the right thing. In fact, I think the proposed regs are really part of the precision medicine cohort. But
they are. They actually are.
Okay. And I think the epigenetics point that we should do education, poverty, fairness, justice is terrific. But let me ask you another question. I think that it's a conceptual mistake. It's just a structural mistake to say that biospecimens are human subjects. I think we went totally off the rails when we said that. And I'm just going to ask you if there's any possibility we can get Jerry and his people to back down from that and say, I think we need rules to protect biospecimens, but I don't think they're human subjects. I don't think they should be under IRB control. I think that this just makes things much more complicated than it should be, or than people want, if they're going to use people's autonomy, and they do, you're right, as the excuse. They say, oh, well, people want to consent to this. Well, how do they know that? You did a survey. I'm
Well, I
willing
mean,
to, I want to look
actually,
at that.
there have been many surveys.
But tell me what you think about getting rid of this notion of biospecimens being human subjects.
I think it's going to be very hard. I think that that they did this in order to get it. Well, they did this to get around the paper I wrote 20 years ago, basically. I think. But you better exclude that from the tape. But you know, I think that they really. I think it's part of response to the Henrietta Lacks story, and although NIH said that was going to be a unique event, it turns out it's not a unique event, and we've come up with this notion that tissues are actually really quite special. I think we have to object to this. The concern I know that many people have is that if we say, well, why are you being more permissive with data? Why don't you make it all like biospecimens? I think that's a real concern. I mean, I think it'll be difficult to say that, that we ought to loosen biospecimens rather than, than come up with some system that treats biospecimens and data the same, because they are the same. I mean, they are the same. With very rare exceptions of, some indigenous groups who, have particular beliefs about tissue. For most of us, those aren't the salient issues. I think it's going to be really a major agenda of the notice of proposed rulemaking was to get rid of the IRB. It was. And so one of the things that I find striking as I think about the precision medicine initiative is that they talk about community engagement, community oversight, things of that nature. Something, by the way, that we've done at BioView from the get-go. I mean, we have all kinds of oversight with what we do with that particular resource. But I think the goal here is to get rid of IRBs. And I think, and what I do think is I think that we need to have more transparency, what research is being done. At BioView, we actually publish in lay language every study we're doing, that resource. There needs to be more accountability. What happens at Vanderbilt if someone were to try to re-identify somebody from BioView is they would lose their job. That stuff is tracked, and people at Vanderbilt, not in this context. I think everybody, the researchers all know better. But, when we have workers who look at medical records inappropriately, they get fired. And so there needs to be accountability. There need to be some penalties for misuse of data. And I think one of the questions you can ask is whether, whether they are things that should be invoked by agencies like Office of Civil Rights for HIPAA, or whether this is something that creates a private right of action, which is notably absent in this area. But I think it's going to be really hard to get rid of the biospecimen exceptionalism. But I think that unless we try, we certainly, we have no chance of getting rid of it. That's my own thought. So, great question, George.
That was great, thank you. So I really enjoyed your epigenetics point, which I agree with. And epigenetics ultimately provides a mechanistic explanation how we've said in our writing how the social gets under the skin. The problem with the epigenetics point is that it shifts the focus for the precision medicine agenda away from prediction, because once you concede that the sort of money in the molecules is in epigenetics, you are conceding that it's a complex dynamic system which has feedback, which depends on multiple forces, which has to incorporate the ecologic as well as the behavioral as well as the molecular. And that is a very different kettle of fish than the notion that we can predict individual well-being from something that is fixed and unchanging. So I guess my question is, what are your thoughts about prediction and where it stands at the heart of the precision medicine agenda, and the likelihood, if any, of shifting that to a much more complex conception of disease causation that is represented by epigenetic thinking?
Well, I think the reason that I picked the epigenetic example is because I think that's something that will be attractive to the precision medicine initiative. I mean, I was just trying to think of something that they would be interested in and that would be intellectually stimulating to them. I do, and honestly, I do see some downstream risks of this. I mean, as I was reading, getting ready for this, I was seeing some people making some arguments that children who have been the victim of child abuse have particular patterns of epigenetic modification. And that always makes me concerned that people are going to regard them as somehow damaged goods in some way or other. But I partly think that first of all, I think that we ought to be thinking about prevention. But I think if we think about just looking at the genome and not thinking about the way it can be modified by the environment to determine who's going to be affected and who's not, I think we're kind of missing the boat. So I guess that's the reason why I'm really interested in that, because we know that most of the genetic variation we see doesn't lead directly to disease. Some people do, some people don't. And sort of looking at the whole panoply of things that may affect the expression of that particular phenotype, I think it's just really critically important, particularly because I think a lot of these factors that public health is so interested in or, expert in are ones that we need to highlight. And so I guess what I would say is I think it's important because I think it will shift the discussion of the debate.
I guess the problem is, to use your term, missing the boat, is that suggests that the entire business of genotype-phenotype association, which is big business, is missing the boat. I'm not sure I want to put you on the spot and on video, but that's the implication of what you said.
I think that looking at genotype-phenotype without looking what mediates it is, if what you want to do is predict health, then I think there's a huge gap there. And I think that, and if you don't look at what's in the gap and what causes some people to become ill and what's not, then you're going to make bad predictions, and you're going to make bad predictions. So, one of the things that I take some comfort in, this is going to sound apocryphal, that one of the reasons I sort of like genomics better than I like looking at neuroimaging is the neuroimaging is a whole lot closer to the phenotype. And so that strikes me as like really scarily predictive in a way that I think genotype is less so.
Talk about the brain initiative another time.
What?
We can talk about the brain initiative another time.
Right, but. Anybody else? Oh, there's a question over there.
Thank you. A question about certificates of confidentiality and maybe discrimination laws. Do you think that the impetus for these changes is really truly more around autonomy, and therefore whether it was confidential or whether there were discrimination laws wouldn't really matter because the issue is someone consenting? Or if we had good protections, good confidentiality protections, like may or may not be in existence related to those certificates, and if we had good discrimination laws, would that solve the problem enough?
It's much more complicated than that. First of all, the law that makes a difference here, there are two laws that make a huge difference in this domain. One is the Americans with Disabilities Act, which actually makes a huge difference, much more so than GINA. And the other one is the Affordable Care Act, by eliminating the exclusion on the basis of pre-existing condition. And I have a personal story to tell about that, which I'm going to share with you. My brother-in-law, Harold, was a sculptor in Texas. He sculpted marble and granite, and he also smoked. And he was an independent contractor, and he had, being the good soul that he was, he had bought private health insurance in Texas for 25 years, had been paying premiums every month all that time. Well, we got a call a year ago last May where, and he told us that he had been diagnosed with lung cancer. And, but why he called was that he had been diagnosed with lung cancer. He had started treatment, and he needed, like a CT and all that stuff you do. And the insurance company said that, oh, we don't cover cancer. 25 years of paying premiums. I mean, I don't get it. And so it was terrible. But the good news is that even though it was after, the enrollment period, because he had a change of circumstances, he was able to enroll in health care in Texas, got a really great policy. There was a month between, when he started and when he could get his policy. So during that month, my husband and I paid for all of his care, which wasn't inexpensive. But, the fact of the matter, before the Affordable Care Act, he would have been out of luck. He would have just plain been out of luck. And so, but because of the Affordable Care Act, he got care for his cancer. Now, small cell lung cancer, you can't cure that, and it wasn't curable in him. But boy, if anybody ever needed convincing, the Affordable Care Act is a good deal. The answer is, yeah, it's a really good deal. And an important change in our society. So, I think the question that we have to ask in anti-discrimination laws is the question we ask in general about anti-discrimination laws, which is, what society do we want to live in? That's why I think the ADA, when I grew up in Houston, I went to a public high school. There was one black young man and one blind young woman, and all the rest of us were upper middle class white. My kids didn't have that experience in school. Your students don't have that experience. It's just a completely different experience. And those are results of decisions about policies that we made. So the question that we have to ask about discrimination is, so what do we want to look like? What do we want to look like? What's our society want to be? That's the question. Now, people are going to have other things about this too. I mean, some people want to know this information. Some people desperately don't. Some people want to share a big reason why older people get genetic testing is to tell their kids. That's why they do it over and over again. I mean, there's all kinds of stuff going on, but the laws that make a difference here are the ADA and the Affordable Care Act, in my experience.
I think our time is up.
Oh, okay.
Everybody, please join me in saying thank you to Dr. Wright Clayton.